So basically, the ones who don't know me, I'm so my disclosures is a medical oncologist at the Catalan Cancer Institute. I'm a medical oncologist. I visit patients. So in my daily practice, I visit some kind of rare tumors and also prostate cancer. Coordinate one area of the oncology program here in Belviche area. And also at the IDBEL, I'm co-chairing one research team with Ramon Alemany, and basically it's the immunotherapy and cancer, and we try to develop our own assets. And in fact, I'm going to put the example and struggles that we have with one of them, no, just kind of like to see the researcher perspective, no, and yes, you're aware, no, this is all Catalonia. This is this is all the areas controlled by ICO, and we are here in the Hospitalet core, no, and we have all this network of reference centers. And since almost a year ago, we have the accreditation as a CCC by the OSC, no, and we are really happy about that. And this is kind of like one of our areas of expertise. Is like here in the campus of Belviche. Probably we are the area in Spain that have more CESUR. CESUR is kind of like the referral network, no, for special situations, and we have all those CESURs just at our hospital, no, just to make the idea of which are our interests, no, and yes, moving from here. No, so as I said, no, we have this expertise in rare diseases and this this interest in these orphan diseases, and here's where ATMs, no, become quite interesting, because we're talking about a group of diseases that together they are really common, probably almost not even like 20% of all cancers, for example, are considered rare. So in global, it's a common disease. The problem is that when we fraction to each one of them, we are talking about really specific, small scenarios. These diseases tend to be quite homogeneous, and some of them probably have really good candidate to be targeted with an advanced therapy. And the problem is that because the market is so small, a lot of these diseases do not have any interest from the pharmaceutical companies. On the other side, we have other common diseases that probably have could have good treatments with advanced therapies, but the problem is that that treatment that you're going to develop probably it's gonna be only being able to be applied to one patient. No, think about the TCRs. No, there's infinite possibilities. And here in the lab, for example, we are trying to find TCRs that recognize specific neoantigens. We are finding them, but the problem is that if we want to move that forward, there's going to be only one candidate for that therapy, no? And that, me as a researcher, that worries me, no? Because here's all the different tracks that we have here in the research group. No, we have we are developing chemical stem cells as a carrier of oncolytic viruses by itself. We are doing academic CAR-Ts. We are trying to find specific TCRs, no, and we are also trying to improve the TIL therapy by adding subchemicals that helps T cells to recover better and maintain the specificity during all the TIL isolation process. But as I said, this is, and Nuri explained really well before. No, imagine all these problems, all these ideas, no, and all the struggles and all the bottlenecks that she described really well. Once that idea, is selected and we want to move forward, no. So imagine us from the research side. Before we have to try to find the best option and move that what we consider is the best option to the clinic. And this is one experience that we had, for example, with allocelivir. Allocelivir, it's two compounds. No, the component A, it's allogenic stem cells that in the case of our clinical trial come from bone marrow derived from patients, bone marrow donors. And we have a second component that is an oncolytic virus. In that case, we use the ICO-5 because it's one of the viruses that we developed, one of our first viruses. So what we do is just put them both together. We infect those mesenchymal cells, and then we put that in the patient, and this is what we call allocelivir. And basically what we are trying to do is those allogenic bone marrow mesenchymal stem cells, they have a tropism to go to wound healing areas, and this one of the areas that share that wound healing signature, it's cancer. They're not solid tumors, and once they're inside, they deliver the lytic component of the virus. The problem now, for example, is that we have in the lab demonstrated that there's other sources of mesenchymal stem cells that are much better than bone marrow. They're easier to obtain, and highly proliferative, and they're more efficient, in any aspect compared to the bone marrow. In that case, we're working with menstrual blood-derived mesenchymal stem cells. And on the other side, the viral therapy is evolving quickly, and we have a lot of other candidates in the lab that probably are much better than ICO-5. ICO-5 is a really good virus because it replicates quickly and it kills the tumor cell. But nowadays we know that we can add other transgenes that codify to cytokines, bispecific, matrix-regulating agents, etc., etc. So the combinations here are infinite. And any of those changes that we see in the lab, that we demonstrate, that could improve the treatment, could be considered a new combination and could be treated as a brand new entity requiring full GMP production. And this is one of the problems that we're finding, as I said, from the academic side. And then at the end, we end up with a situation like this. We have what we consider the best biological product, but we end up using the available GMP product. In that case, for example, knowing all that, why did we use mesenchymal stem cells from bone marrow, and why did we use the ICO-5? Basically because our collaborators in Madrid had those cells already in GMP, and because we did a clinical trial in patients, we still had GMP-produced ICO-5, in that case, for example. And this is what Nuri explained, and this is how we see that as a researchers. We have all these ideas here that they're continuously getting better, but then we have to pass that through all the regulatory pathway. And of course, as I said, I'm a cancer doctor. I want to treat patients. I have to do it the best way possible. And and that's why we have to team up with all of you in with other expertises to try to make it that possible. But it's, as we hear from the previous speech, that's really really thin bottleneck, and a lot of those possibilities, they're just lost in during the process. Then so we're an academic center, and we know that we cannot compete with pharmaceutical companies, for example, and as an academic center, so for example, a lot of our ideas are centered in those specific areas when there's less commercial attractiveness or viability. In that case, as I said, special situations, small patient populations, rare diseases. And this makes also, so as I said, we're not competing with the pharmaceutical companies, but pharmaceutical companies adapt and change quickly. We are not able to adapt and change that quickly as they do. And in fact, we are seeing a situation right now that we're generating all these clean rooms to use CAR T cells. And we know now, if you are going to congresses and all these things, that pharmaceutical companies are not interested in CAR T cells anymore. like the concept of CAR T cells, no, that we are doing right now. They are going to CAR T cells, but like in vivo, no, CAR T cell production. So put the vectors in the patient no, start growing their CAR T cells, no. So there's this competition, as I said, no, that's unfair, no, that's this competition, and they adapt quickly. We are not adapting that quickly as they do. They already presented in the previous speech also the hospital exemption. We are trying to use that. No, pues yes, we are trying to. So I'm not gonna get into the framework, but that allows us to bypass some of the strong regulations that there could be for products that are trying to seek a commercialization use. But it has a series of requirements that we still have to accomplish, no? And also there's interpretations, no, to the hospital exception that when I've had calls with Spanish agencies to discuss some of the projects. No, sometimes one day they interpret some kind of things in one way, no, and sometimes they, no, and that's also another challenge that we have. No? All this, no, so I'm, because of the sake of time, I'm passing some of the slides because they were a little already discussed in the previous talk, but all that also require infrastructure. No, I think here in Catalonia we're in really good situation. Nuria presented really well all the ecosystem dynamic, really strong interest. Hospitals, and research centers with interest on all these therapies. The creation of the BioCat, it demonstrates, that position, to try to not regulate but facilitate the development of these structures. But I think we are a little in a crossroad also, that we have to decide, which model. No, how do you want to create that model? No, so I think academic manufacturing. So do we need it? No, localized GMP capacity in hospitals. No, the public investment, of course, is needed, and also the third pillar, it's going to be the selective industry partnership from some of that. And in that regard, so for example, we're talking. Nuria presented all these white rooms, the clean rooms that we already have, and we're going to develop. No, and as I said, we have to think about that, because if we do not organize that, we can generate, I think, what it would be the worst scenario, that with a decentralized model where every hospital and every works as an independent core. Probably the completely centralized model, I don't know if it's the best option. So because me as a researcher, so I'm depending completely on another institution, and that other institution can have other priorities, other sex, but probably we can go towards a more hybrid model where there's a core facility that probably allows not to duplicate different structures in the hospitals, maintaining some of the production in the hospital. And that's something that as I said, I don't have the answer to that question, but that's something that we are at the moment that we have to decide which model do we have. And this is a pros and cons of each model. As I said, the hybrid, for me it would be a better scenario. Decentralized, as I said, we as a center have there's some aspects that we cannot control, and also there's the legal viability, because that's one of the things that sometimes I've discussed with Spanish agencies, that to do the hospital extension, this requirement that the whole process should be done in the hospital. And as I said, sometimes I found people with really strong advocates of that, and other times when we make a consultation, no, they're a little more open, no, and no, but that's something that we have to take into account, no, and for sure, no. So if advanced therapies are only developed where there is a market, no, many patients will never have access, no, and academic hospitals must be part of the development of that pathway, no, and that's my final message. Thank you.